So I'm pleased to talk about the possibility of hepatitis C control. And I think many of you know that the World Health Organization set targets for the year 2030 for global control of viral hepatitis. These are ambitious targets by their own admission. And what they're asking is that we try to achieve a 65% reduction in liver-related deaths, an 80% reduction in new hepatitis virus infections, that we diagnose 90% of infected patients, and that 80% of infected and eligible patients begin therapy. So why have these targets been set? Well, probably first and foremost, because the problem of viral hepatitis is a very large and increasing problem. So in this graph, we show the number of deaths on this axis. The y-axis shows the number of deaths in millions caused by the 4 leading infectious disease causes of death. I think the diseases that come to mind readily are malaria, HIV, and tuberculosis. But it's important to realize that chronic hepatitis B and C actually are among the 4 big infectious disease killers. And there's another thing, in addition to the fact that they're not the most commonly thought of, there's another thing that's unusual about them compared to the others. And that is the graph for hepatitis B and C, which is in blue, is the only that is on the rise over the last several years. And in fact, extrapolation of data suggests not that we will have control over a 65% reduction in deaths from hepatitis B and C, but instead a dramatic increase in people dying from this. So this is part of what drove the World Health Organization to direct our attention towards control of these really important pathogens. The other problem is, or the other reason to target viral hepatitis is a more positive one. It's that we have the promise to do so. There are now vaccines against hepatitis A, a newly licensed vaccine against hepatitis B, and a vaccine against hepatitis E. We also, as you know, as was very thoroughly discussed, have great capability to suppress hepatitis B virus infection and now the capacity to cure with simple and well-tolerated regimens hepatitis C. So this really stimulated this interest in trying to control both. So in order to achieve control, probably very simply put, we need to reduce the number of HCV infected people, and that reduction in the number of infected people must be much greater than the number of new HCV cases. Or graphically, we can say that the good way of eliminating people from the hep C infected pool, curing, and the bad way, which is losing our patients to hepatitis C, those combined have to exceed the number of new infections, and they have to do so substantially in order for us to meet these WHO targets. So where do we stand on this? This is really going to be a significant challenge. So Andrew Hill and colleagues extracted epidemiologic data for 210 countries in the year 2016. And the first problem was the vast majority of countries can't actually tell us how many people have hepatitis C or how many of them are being treated and cured. But there were 91 countries out of the 210 that had enough data to even ask the question of whether the number of people being pulled out of the infected pool is greater than the number going in. And so of those countries, unfortunately, 54 of the 91 countries with good data had more new HCV infections than cure in 2016. And more unfortunately, there were 21 of those 91 countries that had more than 5 new HCV infections for every person who died of or was cured of hepatitis C. And so if SVR, or sustained virologic response, the number of people is shown on the y-axis in 2016, and the number of new infections is shown on the x-axis. And this is not the only study to show this, but when you look at the net HCV drop, meaning the total number of people who were cured over and above those infected, we lost only 0.7% of the total hep C infected population in those 91 countries. When you extrapolate those data to the rest of the world, we do even worse. As I mentioned, there are about 70 million people infected with hepatitis C. And since the rollout of these incredibly potent drugs that are highly effective and well tolerated, we have about 70 million people infected in the world. So it's estimated that we lost about 0.4% in the total burden of Hep C. So another study that really asked a similar question, but in a different way, was a study by Marcus Kornberg and Homi Razavi. This is a more recent study, a 2019 study, that assessed the progress made. This was restricting the analysis to 45 high-income countries in meeting the 2030 WHO targets. And what they found is that basically 80% of these high-income countries are not on target, and that 67% of them are off by more than 20 years, meaning they won't eliminate Hep C or even control it substantially by 2050. So where are these countries? The red countries, including our own, are the countries that will not meet these guidelines by 2050. The green countries are the countries doing well. They will eliminate HCV and meet the guidelines if things stay as they are by 2030. I'll give you some reasons why things might change. And then the other countries are in between. So where are they falling down on meeting these guidelines? Most significantly on reduction in incidence. So of the 4 WHO targets, and again, we're looking at 45 high-income countries, 34 of the 45 could not meet the target reduction in incidence by 2030. There were problems with mortality, treatment, and diagnosis as well, but this reduction in incidence is going to be, based on current data, the biggest challenge in this effort to control. So what about global incidence? The data don't look much different today than they did in 2015 based on some recent studies. The data are showing that there are about 1.75 million new HCV infections each year. It depends on where you are in the world as to what the risk factors are for the acquisition of HCV, whether it's bloodborne through contaminated medical equipment, if it's injection drug use. But the incidence is high in most regions of the world, and again, because the reporting is not perfect on this, there is a range. But even with a range, you can see that at minimum we have at least 1.5 million new infections. In the United States, actually in all of North America, an additional compounding and problematic factor in this is the opioid epidemic. It's an epidemic of both opiate use and overdose, with which we're all unfortunately very familiar. And the net result is that unlike the curve for hepatitis B, which shows that again, partially as a result of widespread vaccine campaigns and vaccine utilization, we see a decline in the number of hepatitis B cases over time. But with this 2010 really is the onset of this opioid epidemic, and what we see is that the rates of new HCV infections in the United States have been rising rather than falling. So there has been really substantial focus, as we all know, on curing HCV, and these cures are really nothing short of a miracle, and I'm incredibly grateful to have them in my clinic. But I want to highlight a few of the downfalls we'll experience if we focus really primarily or even solely on cure. Treatment remains expensive. While the cost of these drugs has come down substantially, they do remain quite expensive. We have already treated many of those easiest to treat. I think we see this in our clinics. We had a flood of people coming into our clinic to be treated in 2014, 15, 16. There are far fewer people seeking treatment. We've really treated many of the people who are diagnosed, who wanted to be treated, and who are eligible for treatment. It's not just us. Basically, we spent about 60 billion US dollars on direct-acting antivirals between 2014 and 17. But ever since the peak of treatment in 2016, we've seen globally a steady decline in the number of people being treated for HCV. So some of those data I showed you where people are actually treating more people than are newly infected because the treatment rates are falling, some of those countries are shifting, and now if we repeated this analysis, perhaps even more than 54 of the 91 countries would see more new infection. It looks that way. As we know, it's difficult to find the people who need treatment, and this is really manifest in the global diagnosis rates. So again, the World Health Organization target is 90% diagnosed, and if we look at the percent of people who are actually diagnosed with HCV, starting with high-income countries on the left and moving to low-income countries on the right, we're really, unfortunately, doing an abysmal job identifying people with HCV. And this is an area where dramatic improvement needs to take place. Unfortunately, the drugs do not prevent reinfection. So what practicing clinicians have experienced is that patients who are effectively treated for their HCV come back in reinfected. This is really a problem for anyone who is at ongoing risk of HCV infection, not as dramatically in healthcare workers as in people who are injecting drugs and men having sex with men, but following cure, we've seen people become reinfected, and this has actually become documented to be a very significant problem in HIV-infected men having sex with men, with some studies, one here showing up to 30% of HIV-positive men having sex with men who've been cured of their HCV becoming reinfected. And again, an important thing to remember is the only way to diagnose them is by HCV RNA testing, because treatment leaves people HCV antibody positive lifelong. So it is important to screen your patients who are at ongoing risk of HCV with an HCV RNA test to see if they've become infected again. And I think importantly, really like with HIV, you want to treat early. And the reason is that we know that these drugs cannot reverse all the damage done from HCV infection. This is one example. These two curves are the rates of, over time, of incident hepatocellular carcinoma in people who are either cirrhotic at the time of Hep C treatment, that's the red bar, or did not have cirrhosis at the time of treatment. There are 2 points here. It's really critical to treat people for their Hep C before their livers are badly damaged. But the second point is that in all cases, we do still see liver failure and liver cancer in people who've been cured of their hepatitis C. So treatment early, before severe disease ensues, is important. And if we could, preventing hepatitis C is also going to be superior to trying to treat our way out of this epidemic. And so with that, I want everyone here ideally to think a bit about some emphasis on prevention of new infections. This is really where we're failing globally, and we need to think about these things. So harm reduction strategies include opiate substitution therapy, needle and syringe services, and safer sex counseling, things that are within our hands and that we really need to try to do as uniformly as possible. Less of a problem in the United States is safety of the blood supply and injections, but this is a problem globally. And it's really going to be very important to treat opioid addiction to remove the risk factor, but also to treat those with HCV at risk of transmitting. People who come in acutely infected with hepatitis C have participated in a high-risk behavior or a risky enough behavior to have acquired Hep C. They are probably continuing to participate in that behavior and therefore putting others at risk. So I think we're going to see a change in the US guidelines on this. There have already been changes in other national guidelines about this wait when someone's diagnosed with Hep C, and I think we may get to an HIV situation where we're going to try and think about treating people when we diagnose HCV. We'll see if that comes, but I predict that is coming, because if we don't treat the people who are transmitting it to others, we're going to continue to have new infections. So what about a vaccine? The advantage of the vaccine is it really provides prevention throughout the world, regardless of the risk factors for acquisition. Unlike opiate substitution therapy, that's not going to be a way to prevent transmission in Egypt, which has a high burden of disease, but not at all through people injecting drugs. In addition, I'll point out that vaccination is really the only successful method we've ever had for global elimination or eradication of pathogens. And I think when people say, well, but we can have cheaper, easier to use drugs for Hep C, I think we should think about syphilis, a disease with which we're all quite familiar. It costs pennies and takes a single dose of penicillin to treat syphilis, and what we're seeing actually is massive increases in the rates of syphilis infection in the United States, not control. So I think if we extrapolate this lesson and the lessons of success, which have almost uniformly been achieved through vaccination, we need to think about a vaccine. Well, that raises the question, is it possible to induce protective immunity against HCV? And the answer is yes, I think, and I'll explain why. I've for years run a cohort called the Baltimore Before and After Acute Study of Hepatitis, or BBASH. And in this study, we enroll people between the ages of 18 and 35 who are not infected with HCV, but at high risk. And we counsel them extensively, but unfortunately, some of them still acquire HCV, with the two outcomes with which you're very familiar. In our cohort, as in many others, about 73% of the people who become infected develop persistent HCV RNA, which is shown in the red bar, and are persistently infected, and 27% clear. Very disappointing to people who are hoping to make a vaccine against Hep C was the observation that the people who spontaneously controlled hepatitis C could, in fact, acquire the infection again. However, what we saw is that in the people who spontaneously cleared HCV and were infected again, rather than having a 27% chance of clearing, they had an 83% chance of clearing. So while treatment does not provide natural protection against infection, spontaneous clearance of HCV does seem to be associated with a robust immune response that is somewhat protective. This is not a fixed genetic trait these people have that make them more likely to clear, although some of them have some of that. Not only did they clear these second, third, fourth infections, they clear them more easily. Their peak HCV RNA is lower, and their duration of viremia is shorter. So they don't just control Hep C again, they do it more quickly and more effectively than the first time. That's adaptive immunity, that's a protective immune response. We want to know what that is and get a vaccine that does that. So can we make an effective vaccine? Just a couple of the problems associated with it. One is the genetic diversity of HCV. So these circles show the size of the HCV-infected populations in countries throughout the world. Then the colors indicate the proportion of the HCV-infected people infected with a particular genotype of HCV. Unfortunately, we have pan-genotypic regimens for HCV, but it'd be really great to have a vaccine that also protects against all the genotypes of HCV. I think you can see if we got a genotype that protected against genotype 1, which is the red portion of the circles, that would at least be a big help. The other challenge is that we really haven't tried to make an HCV vaccine. So if starting at the left of this chart are the various ways you can see that the various things that have been tested to induce robust immune responses against HCV in rodents. Then a subset, and a very small subset of those tests have been moved into macaques and chimpanzees. Only proteins with adjuvants and viral vectors encoding HCV antigens, which I'll explain a bit more, have been tried in people but not at risk for HCV. And there's actually only one vaccine to date that's ever been put into people who are actually at risk of HCV infection. And I'll talk a bit more about that. So the strategy in this vaccine was to use vectors or viruses that are relatively immunogenic but not harmful to carry something that stimulates an immune response to Hep C, hepatitis C antigens. And these are designed to really induce robust responses to the antigen carried, or the Hep C part of the vaccine. And this was actually tried using a prime boost strategy. So the first vaccine was a chimpanzee adenovirus encoding Hep C proteins boosted by modified vaccinia Ankara, a vaccine that was used to vaccinate against smallpox. And the antigen, or the part of Hep C contained, is the non-structural proteins. And this actually was tested, as I said, it's the only vaccine tested in people at risk in a double-blind, it was called VIP, Vaccine as Prevention, a double-blind randomized placebo-controlled trial that took place at 3 sites, Johns Hopkins, the University of California, San Francisco, and the University of New Mexico. And it was a population similar to BBASH, young people who are injecting drugs and at high risk. Enrollment was completed in 2016 with 545 people in it, and the goal was to assess safety and prevention of progression to chronic infection. So not incidence, but progression to chronic infection where we see all disease. 2 injections, as I mentioned, the first followed by a second 8 weeks later, and the immune response was assessed. We looked for infection by testing for HCV RNA. And unfortunately, while the vaccine was quite safe, it did not meet the endpoint for reduction in progression to chronic infection. More details on the vaccine trial results will be released this fall. So in conclusion, I think we are far behind where we'd like to be on control of HCV and elimination targets. It's really important to employ the harm reduction strategies we have at hand to treat opioid addiction, to diagnose, and I think we're moving towards earlier treatment of HCV as we did with HIV to really make sure we treat the population at risk for transmission. And I would ask you to consider advocating for an HCV vaccine. And actually, don't ask me any questions yet because it's not time. But thank you very much for your attention.